Hello everyone, I'm Sadaf Marashi-Pour, and in this presentation, I will talk about sepsis within 30 days following elective surgeries in New South Wales public hospitals during January 2015 to December 2017. Thanks to Dr. Diane Watson for her contribution to this work and this presentation. The Bureau of Health Information is a board-governed organization that provides the community healthcare professionals and policymakers with information that enhances transparency of the performance of the healthcare system in New South Wales in order to inform actions to improve healthcare and strengthen accountability. New South Wales is the most populous state in Australia with about 8 million people. The publicly funded healthcare system, New South Wales Health, employs over 110,000 people, working across more than 200 hospitals and clinics around the state. Each year, there are more than 1.9 million hospitalizations and almost 3 million emergency department visits. Hospital-acquired complications can have serious impacts on patients and their families by affecting recovery and overall health outcomes and resulting in lengthier hospital stays. Post-operative sepsis is a common complication, accounting for 1/3 of all sepsis cases and associated with a higher risk of mortality. Clinical risk mitigation strategies may reduce but not eliminate the risk of hospital-acquired complications. Accordingly, information on variation between facilities in hospital-acquired complication rates can support the identification and management of patient risk to support better value care. Therefore, the aims of this study were to investigate rates of sepsis within 30 days following elective surgery and to explore variation in risk standardized postoperative sepsis across New South Wales public hospitals. The indicator was developed through extensive literature review and engagement with clinicians and advisor committees. In order to fairly explore hospital variation, we used risk standardized postoperative sepsis ratio, which compares each hospital's postoperative sepsis results, taking into account its case mix with an average New South Wales hospital with the same case mix, calculated as a ratio of the observed to the expected number of occurrences of postoperative sepsis. Expected numbers calculated using a New South Wales level prediction model using fine and gray competing risk regression, taking into account patient level risk factors outside the control of the hospitals and the competing risk of death. Outliers were identified using funnel plots with 95% and 99.8% control limits based on Poisson distribution. We used linked admitted patient data collection, which includes all admissions, including electives and emergencies and public and private hospital data, and registry of birth, deaths, and marriages for these analyses. Using these data sources, we were able to follow patients' entire journey through public and private hospitals. Transfers were taken into account, and multiple acute contiguous hospitalizations were considered as a single acute period of care. In this slide, you could see the inclusion and exclusion criteria which form the index surgical cohort. Acute elective surgical hospitalizations between January 2015 and December 2017 among patients aged 18 years or over, where the initial surgery was performed at a public hospital, were included, and previous 3 years periods were also used for looking at trends and validity analysis of the prediction model. Some of other exclusion criteria include those with the diagnosis of sepsis, where the sepsis occurred prior to the index surgery, which was less than 1% of the surgeries, and those with the diagnosis of infection, which was around 7%. And overall, 59% of the initial surgeries were performed at private hospitals, taking into account transfers. The outcome of interest was secondary diagnosis of sepsis, whose onset had occurred during the first index surgery, or primary diagnosis or secondary diagnosis present on admission of sepsis within 30 days following the index surgery. diagnosed in any New South Wales hospital, public or private, same or different hospital. Like all other decisions, attribution of the index surgeries and the outcomes to the hospitals is a decision that we take very carefully. I mention here a couple of our attribution decision rules. Overall, and in case of patient transfers, index surgeries and sepsis were attributed to public hospitals that performed the initial surgery. Although private hospital data were included for accurately following patients' entire journeys and construction of surgical periods of care and outcome identifications and attributions, but our results focused on index surgeries at public hospitals. Also, in cases where more than one sepsis occurred within 30 days of an index surgery, only the first sepsis was counted. Some of the risk factors included in the development of the New South Wales prediction model were age, sex, Elix-Hazard comorbidities, history of sepsis, previous surgery, and major diagnosis category with relevant look-back periods. Only variables significantly associated with the outcome were retained in the final multivariable model. We evaluated the prediction ability of the model using C-statistics in data from the current and previous time periods, which was more than 0.83. The stability of the coefficients during different time periods was also tested, and results were reasonably stable. And factors included in the final model and their direction of association with the outcome were reviewed by clinicians. Rate of 30-day postoperative sepsis was around 1% among 66,143 adult elective surgeries at public hospitals that met the inclusion criteria during 2015 to 2017. Results showed around 33% of postoperative sepsis were identified during either a transfer or readmission to hospital. Hospital-level unadjusted rates of postoperative sepsis ranged from 0% to 2% across more than 80 New South Wales public hospitals. As you can see in this funnel plot, 3 hospitals were located above the upper 95% control limits, shown with the red dots, and were identified as having a higher than expected postoperative sepsis. Results show a considerable number of occurrences of postoperative sepsis would not have been captured if linked data was not used, and only complications recorded during the surgery hospitalization were considered. Our findings highlight the need for further analysis of linked hospital and primary care data to better understand the issue. The majority of New South Wales public hospitals had postoperative sepsis results lower or no different than expected. These 30-day risk standardized postoperative sepsis results may prove useful as a screening tool for quality improvement in this area. We thank the New South Wales Ministry of Health for access to population health and hospital data, and the New South Wales Centre for Health Record Linkage for linking the relevant datasets. We thank members of advisory committees, the Patient Safety Measurement Advisory Group, clinical advisors, and colleagues at the New South Wales Ministry of Health for their contribution to this work. Thank you for listening to this presentation. Please look at our website for details on BHI reports, and please feel free to contact me if you have any questions. Thank you again.